But my biggest claim to fame is that I was one of Marshall's residents. Thank you, Marshall. Okay, what is this? Is this the... Okay. Well, you did ask me that question, I have to say. Well, I am not an educator, and I never really imagined being on a stage panel with educators, nor especially my master educator, mentor, Marshall Wolf. So understand that I'm a little bit of a fish out of water. But I'm very, very excited to be here today to talk to you about a new teaching program that I'm working on with actually one of these wonderful residents over here, Lanny Santo from Kaiser Oakland. Many people will agree that traditional approaches to medical education have often left the human elements out of the doctor-patient relationship. And so this program that I'm going to describe to you uses personal narrative and story to reconnect us to those pieces of ourselves that we may have left behind. Now, you know, changing medical culture and behavior is hard, but, and I'm sure all of you out here know that if you're in the education field, but it's critical that we change our culture in medical education and on the wards. Our current culture is siloed. Sorry, I'm falling behind here. It's siloed. It's super specialized. It's organ-focused, and it's certainly not patient-centered. And this is leading, as, again, many of you, I'm sure, will agree, to a lot of suffering. And that suffering is really not just the patient, but it's really all of us. For the patient and family, for example, we are essentially treating them as widgets on what I call the end-of-life conveyor belt. We have taken the person out of the patient. We are following protocols. We are sending patients oftentimes from the intensive care unit into ventilator facilities attached to machines. And of course, surrogates are traumatized and devastated. And healthcare providers, I believe, are suffering from profound moral distress and burnout. And we're hearing a lot more about that. We're no longer seeing the human in the bed. We're not seeing the human in the white coat either. And, you know, the question is, how can we access the humanity that we may have left behind and that the modern practice of medicine has essentially begun to deprive us of over the past 40, 60 years? How do we rediscover our compassion? How do we change the behaviors that we've been taught on the wards? Well, to be sure, data, training, and skills are critical. But ultimately, to reconnect with our humanity, I think we need to open ourselves emotionally and to rekindle our empathy. And that is exactly what story does. So, story creates empathy by bearing witness, allowing us to bear witness to others' experiences, by creating a safe space for vulnerability and for sharing, by inspiring humility and openness to other people's experiences, and honestly, by moving us. And actually, there's also data to support narrative strategies in education. There are data that show that reading fiction increases empathy. Narrative strategies engage learners before cognitive or skill-based interventions. And increased empathy, which can be achieved, is actually sustained over a long period of time. So the narrative medicine movement really kind of started getting legs in the 1990s when we had the birth of programs like On Being a Doctor in the archives of internal medicine, The Healer's Art, which many of you have probably heard of, which is in many medical schools now across the country and inspired by Rachel Naomi Remen's book, Kitchen Table Wisdom, I believe it was. And Columbia Narrative Medicine program started in the year 2000. Rita Sharon led that, and now there are several narrative medicine programs throughout the country. And in 2010, 2010s, the graphic medicine movement was coined as a phrase by Dr. Ian Williams. I think it was in 2015, actually. It's relatively recent. Now, I fell into this movement myself. Now, I've been writing stories for a long time about my work in the ICU and even before that, just sort of stories to process my own moral distress, my own experiences, my own difficulties in doing this very, very difficult work. And what I found was that I wasn't the only one who needed these stories. I started finding that people were interested in reading it in places like the New York Times, and I started publishing pretty regularly there. And then I was lucky enough to get a book contract from Penguin, and I wrote my book called Extreme Measures, which is filled with stories. And then I was able to convince a filmmaker to come into the intensive care unit where I work and to create a documentary called Extremis, which shows several of the stories, some of which are actually in my book as well. And to my surprise, these stories in these formats resonated with people. And I was starting to hear that educators and lay leaders around the country were using these frequently as tools in their own teaching. And I actually stopped counting after getting about 150 or so emails, alerts on my social media of it being used in a variety of different locations. So I started to realize that these stories were a teaching tool. Columbia Narrative Medicine Program invited me to come and speak there, and then they put me in touch with a cartoonist named Ben Schwartz from the New York Times, who is going to be taking some of the stories from my book and making them into cartoons. So these, all of a sudden, these stories were being put into a whole eclectic collection of media, and they harness all the themes that I think about a lot and talk about into, again, film, movie, cartooning. And I realized with all this use that there should be some sort of a formal program to harness it in a way that I thought would be effective and helpful. And so what I thought would be helpful is to give you a quick taste of some of these materials and what they are, and the themes that are addressed by them. The book consists of about 60 short patient stories. It's narrated by me, a senior clinician by this point. I know, Marshall, it's hard to believe. And it really, the learner or the reader hears me struggle with a lot of emotions that we don't tend to talk about in the real world of medical practice. The shame, the fear, the uncertainty, the anger. I don't always look so great, I'll tell you. And the hope is that this invites people to then feel more comfortable sharing their own struggles. For example, let me give you a quick show of the fear of being wrong. I have a very short excerpt that I'm going to, I hope it's going to work, but let's see. How in the heck do I do this? Well, it's supposed to play, but I'll just read it to you. This is actually the summary of a story that I write about in the book, which talks about a very painful case where I made oh, there's someone's, not quite yet. I made a prognostication that ended up being wrong. I prognosticated that someone was going to do very badly or probably die in the hospital, and he was still alive years later. And so let's quickly play this clip. If it doesn't work, I can just read it myself. Why don't I do that? In my opinion, one of the most powerful determinants of physician behavior is the fear of being wrong. There are a small number of cases that will haunt my practice forever, their memories stifling my desire to speak the truth as I see it. These were patients whose prognoses I thought extremely dire, but who, against all odds, had rallied and survived. Or at least didn't do as badly as I had thought they would. And these memories sometimes render me wary of speaking the truth as I see it in similar cases. I can count these cases on one hand, but I will never forget them. If I hadn't processed and talked about that experience, I call that my say chin moment. I named the patient, and it's not his real name, but it was the name whenever I have this experience and I feel like, oh, I don't want to prognosticate. I don't know if I'm really right that this guy's not going to do well. I think of my Say Chin moment and the fact that I was so wrong with this patient. I could have given his family this sense that he was going to die, and maybe they would have made a different decision than they actually made, which was to continue with the surgery that I was suggesting might not be that helpful. And so it really makes me not want to sometimes give a poor prognosis because I'm not completely sure. And I think that is the kind of feeling and the kind of experience that needs to be processed. Otherwise, you get stifled by those kinds of emotions, and it can affect your practice, and you can not feel liberated to be honest and truthful with patients. So that's one example. I'm going to play another short clip from the movie, Extremis. And again, let me tell you that movie focuses mostly on 2 patient stories, and those 2 patients are actually written about in my book as well. This clip brings us to another theme, which is the fear of being, it's actually also the fear of being wrong. This is a double whammy, but this is another clip that shows that fear. And here is my colleague, Monica Bargava. Oh, it's not showing? Oh, sorry, because I'm not pressing forward. This is my colleague, one of my ICU colleagues, and we are actually sitting and having a conversation about a patient who is really, really not doing well, and you'll hear what she says.
Suffer or have anything prolonged or painful, I just want them to make a decision with the best information available. And I feel that as of right now, as of today, we haven't had, an expert in her disorder weigh in on what her prognosis might be.
My biggest
fear is telling a family that there's zero hope when maybe there is.
She and I are both pulmonologists. This patient had end-stage neurologic deterioration with a progressive neurologic dysfunction from myotonic dystrophy. This patient, she and I both knew, would never be extubated. And yet, she did not feel comfortable telling the patient and the family of this very, very serious prognosis now that the patient had actually gotten on the ventilator, because she thought we should wait and hear from an expert in her condition, an expert in myotonic dystrophy. This is really, it raises this type of question, which is, how much certainty do you need before you can render a prognosis or an opinion? And again, we can always wait for that next expert to come in and deflect and defer putting off that bad news. And it's something that is really tempting to do, but I would argue it's something we should be planning for and thinking about and reflecting on so that we don't withhold critically important information from our patients. So this program is a story-based, narrative medicine-based approach using an experienced yet, I hope, vulnerable narrator that welcomes in other people's vulnerabilities with a multimedia spin on narrative medicine. And this kind of program I sort of call a priming program, a priming tool, which basically in and of itself doesn't have any skill, but it could be, it's not teaching any kinds of skills, but it could, by opening people up to the topic, by making people invested emotionally in the importance of engaging in this topic, could make people more intent upon learning those skills which are critical, like programs like VitalTalk, which do teach communication skills. You can't just foist those types of things on people who aren't willing and bought into the concept. So hopefully this priming tool is something that actually can give people more of a sense of investment in this topic. And so, again, in summary, what we're going to be doing is using the accessible vehicle of story to tackle a subject that's often avoided, using an experienced, vulnerable narrator, hopefully to welcome people into this topic, and use this multimedia approach, which I hope engages many different types of learners, not only consuming the media, but also then expressing it, maybe doing some drawing and writing exercises as well. And it could be, again, standalone or paired with another type of skill-building program like VitalTalk. So thank you so much. We're going to be doing a demonstration of it tomorrow at 3:30 to 4 at the residence section. I hope people will join us and see what you think. It's the first time we're going to be doing it and administering it. I'd love anyone's feedback. Thank you for having me.